Good morning to those of you here in the West, and good afternoon to those in the East. We thank you for joining us today at Let My Doctor Practice Summit at the Summit. Today's topic is reducing regulatory and paperwork burdens and simplifying and reducing healthcare costs by eliminating the middleman in many areas of medical and surgical practice by providing direct patient care and possibly other alternative practice models. Before we move on to today's topic, I want to recap with my colleagues here for a moment the highlights of yesterday's EHR and meaningful use discussion. Dr. Dan Craviotto is with me again, Dr. Judith Thompson.
Good morning.
Good morning.
Judy, what did you think about yesterday? What stood out for you?
For me, the most important takeaway message was to take federal incentives away from EHRs and let the EHR companies deal directly with the end users, and this problem will right itself quickly and we can all get on with the practice of medicine.
Very good. I agree. Dan?
Yeah, along those lines, I think we heard that that due to high tech and the mandate that this caused really unprecedented pressure for physicians to buy into electronic health records at quite a quick pace, and then a lot of these systems were developed because they were rushed into the market because of legislation and adopted quite quickly. They were rushed out without any proven efficacy, poor usability, and interoperability. So that's what I learned, that we took the free market out of it, and then we got a product that probably is not as ideal as it should be.
I agree. And I think it's important to point out to everyone, and the public especially, that most physicians, I think, are not against computerized records. Almost all of us, like everyone else, use computers and smartphones, and we're doing it now with this webcast, and we wouldn't have it any other way. I've been using computerized records in my practice since 2005. The problem EHRs we're talking about are government-mandated, government-decreed EHRs, which do not allow those who use them to modify them and improve them. I have to say also, one of the, I thought, really exciting things that I heard yesterday, and to anyone who didn't tune in yesterday or missed any of these talks, they're all available on demand. And we really had some great speakers and interesting conversations yesterday. But the most exciting thing to me was Senator Cassidy's call for physicians in this conference to submit some specific language as to what we'd like to see in an EHR reform bill.
Yeah, I thought that was very moving, and the same thing. If you did not have a chance to view yesterday's webcast and the speakers, and you're a physician in the United States or elsewhere, I would highly encourage you to watch it because it was very engaging, very moving. I learned a lot. I think the other thing that came across, if I might, by all three speakers is this, the importance of physicians speaking out about topics and issues that the public and really our elected officials too want to hear from us. And so I think every speaker mentioned that too.
Good. Judy, any other thoughts at the moment?
I thought it was very well said yesterday. Maybe you said it, Michael, that if any one of us had purchased a smartphone that had the functionality of the EHRs that we're being compelled to use at this time, that smartphone would have been off the market very quickly. It just would not have lasted. It was well said that at this point in history, physicians are serving electronic health technology in the hospitals and in their offices rather than technology serving us. As you said, we're all ready, willing, and capable, but this needs to help us do what it is that we're trying to do. And again, as you said, Michael, that's going to involve physicians participating at the developmental level, where I don't have reason to believe that they have been. I can't speak to that issue factually. There may be more physician participation now as we see second generation software coming through. A question in my mind, and I did put a call in this morning to one of our health IT executives. I've not yet heard back. I expect I'll hear back from him. Is how do hospitals plan to pay for the second generation software that's coming through? There was a big federal incentive that resulted in this initial implementation, but hospitals, very much like private offices, have meaningful use criteria to meet, and those criteria become increasingly difficult to achieve. And if you don't achieve those criteria, then you lose your federal incentive to use whatever tool you have. And as I said, the second generation software right on the horizon for the hospitals. Teams of people are needed to get them up and running and train the rest of us, nurses, physicians, technicians, to use them. It's very, very expensive. So I believe Steve Stack in the AMA webcast last night said, and if it wasn't Steve Stack, then I apologize, I'm quoting somebody else from yesterday, that meaningful use has failed. And meaningful use, in my mind, as well as government incentivized electronic health records, maybe should just go by the wayside, and we should let the free market step up and do what we have evidence that they do very well.
And yeah, exactly right. And the other thing is that came across is, you know, if it's the goal of policymakers in healthcare to have widespread adoption of electronic health records, then this idea that the way to achieve that is not by legislating it, not by mandating it. You have to think of the end user, and the end user is the physician. It would seem to me that there would be interest by electronic health record companies to realize that we have to please the end user. We want to give the physician what they need to practice medicine, to do what they do. And there also has to be a realization, because I think sometimes we say this and they go, I don't believe it. But what we do as physicians and in healthcare, I think, and the way we use IT and computers might be, and probably is a little different than the business community or the investment community. So there has to be a recognition by electronic health record companies and vendors that, yes, we do realize what you do and your needs are different, and we're going to work with you at that. I think there has to be that recognition and realization.
Yes, agreed. And I want to explain to some of our listeners, I think some or many may not know this, especially in the public, how this meaningful use has come about and caused all these pressures. My own exposure to it came when I left my private practice in 2010 due to these multiple pressures that just made it financially not viable. And one of those is our government taking our own tax dollars and using them to favor hospital provided health care instead of private practice or clinic provided. And it seems to be that there's a theory that patients get better care in those big systems. I don't know of any evidence to prove or support that. But the government is paying more to hospitals for the same procedures than they are to these private offices. So that's driving, along with other problems, driving private physicians by the hordes into employed practice. So I was one of them, and in 2010 closed my private practice. That year we had been given an award by our malpractice carrier, American Physicians, for placing in the top 3 of 877 of their on-site practice evaluations. And yet, despite that fact, couldn't really make a living at it. I probably made $40,000 that year. net take-home. And when I got to the VA, I'd worked there part-time before. I had a great staff, and I was back in with the same staff. And things were going pretty well, but there was something new there that hadn't been there before, and they called this clinical reminders. And I didn't know what it was then, but it was actually the VA's version of meaningful use. So every time I saw a patient, including a walk-in, which we were required to work into the schedule, which was fine, but there might be 3, there might be 10, there might be 15 of these clinical reminders pop up. A lot of them are preventive type questions. Have you had your cholesterol checked? If you smoke, have we talked to you about quitting smoking? And a lot of them I really believed in and did in my practice, but to work those into every visit was just kind of a disaster. Sometimes it would pop up and say this person needs a new history and physical. So to be properly done, that often takes half an hour or more. And again, this might be someone who just walked in and you're being squeezed into the schedule. So then the doctor's faced with a dilemma. Do I actually go through these things and actually do them? Or do I just commit fraud, basically, and just check them off so that I can get to the patient's concern? The patient may be having chest pain. I don't know, is he about to have a heart attack, or is this just heartburn? So I was talking with someone from the director's office one day, a month or so after I got into that position, and he said, how's it going? I said, it's going real well, except for one thing, these clinical reminders we do every visit. If they were done once a year like I did in my private practice, they would really be great. But they should not be done every visit. And he said, well, that's never going to happen. That's not going to change. And I said, well, really, why? He said, because the administration gets a big bonus if you check off all those boxes. And I said, oh, really? And that's exactly what would happen. If you didn't check enough of those boxes off, within minutes, someone from administration would be down there to stand over your shoulder and make sure, watch you click those boxes. They never ask, did you actually do the service that you're saying you did? They never, ever asked me, did I address the veteran's concern? They just wanted to see that box clicked. Well, I fought it for a year, and then I left the VA, went to another employed position, found the same thing. And then another employed position, same thing. And in each case, what would happen is the chief medical assistant would come by, having been instructed by the administrators on what the doctors needed to do in order to keep those bonus checks coming in, and tell the doctors how to practice, how much time they would practice, how they would document, what boxes they would click. So I finally stepped back and resigned and just didn't practice medicine for a while. I said, what's going on here? And did some research and realized that it was this meaningful use program. Excuse me. So during the recession, 2008, 2009, as part of the economic stimulus recovery, the Meaningful Use of Electronic Health Records Commission was created. And the government reasoned, well, physicians and hospitals need to ramp it up in adopting up-to-date computerized records. Many were still on paper, and we're going to encourage that and stimulate the economy. There's a wonderful article that describes how this went down in New York Times, February 19th, 2013, by Julie Creswell, entitled Profits, a Shift in Digital Data Swells Profits in an Industry. And so the healthcare IT companies really lobbied this commission heavily in Congress to pass certain criteria. Now, this commission was composed of 23 individuals, 9 of whom were physicians, but only 2 of them were practicing physicians. So they came up with the criteria which would be used for mandated electronic healthcare records that almost every physician in America uses today and is subject to. The incentives that they pushed Congress to attach to this were on a per doctor or provider basis. So they might be 40, 60, or together $100,000 per doctor or provider. Well, since these doctors were being driven into employed practice, it was no longer the doctor for the most part. It was the employer and often the non-medical employer that was going to receive this money. And that's when I understood this is why this is happening. These employers have this big bonus that they're trying to collect, and they do not look their patients in the eye. They did not take an oath to care for them. They do not sign the documents and the orders, and they do not take personal legal responsibility for the outcomes. So they really have no disincentive not to force their employed physicians to practice according to these criteria set up by mostly non-medical personnel. Anyway, I just wanted to explain to people why a lot of this that we've been talking about yesterday is happening.
Yeah, I thought you summarized that very clearly, and you know, in your comment that, you know, if you're a physician just trying to take care of patients, all of this becomes very frustrating. And if you're a conscientious physician and that's all you want to take care of is the patient, and you've been through 4 years of college and 4 years of medical school, and my case, 5 years of orthopedic residency and 22 years of practice, and my intent is just to take the care of patients the best I know how, and then because of a legislative mandate, something is thrown at us that prevents me from doing that I can't do that as well as I used to do it. It just feels so intrusive and so wrong. And, you know, I think the patient and the public need to understand that. So I thought you summarized it great.
Well, thank you, Dan. And also wanted to say that I had a fully computerized record, a record system that I designed myself along with an IT consultant in 2005. It was absolutely magnificent for taking care of patients. It was very simple. The entire system cost $15,000. Most of these government-mandated systems are $100,000 and up. They may be millions if you're talking a larger practice or a hospital. Right now, I'm using a cloud-based system, Atlas MD, which again is physician design and is really good for taking care of patients. So it's not the computer we're against. Judy, anything to add?
Yeah, change is needed, and we are responsible for the change that is needed. There are multiple opportunities available to us now to reach out to our elected representatives, as well as hospital executives, EHR designers, and it's time for each one of us to look for whatever opportunity is available to us. Of course, we have the opportunity here through the Summit at the Summit. The AMA last night had a webcast, and a number of physicians. I have to say, I was really impressed by the passion that was exhibited by the physicians who came to the microphone in that webcast last night and reported how the EHR systems with meaningful use as we have them now have interrupted the care that they provide. As we said earlier this morning, time for action is now. We are all responsible for this action. Senator Cassidy from Louisiana yesterday asked for our input in formulating legislation. It's my understanding that he's part of a committee that is addressing this issue.
Right. Help committee.
And is he the chairman, or is he a member of the committee?
He's a member of the subcommittee, and I know, and it's a number of things, one of which is health.
Okay.
So he's a member of that subcommittee.
So I think every one of us should take the opportunity to make a phone call or send an email. It can be brief, and let your voice be heard. If we will come together in a united way, we can begin to effect change.
Mm-hmm. Yeah. And I just want to echo that too, that we are not against electronic health records or the computer in any way. I think the computer is a very valuable tool in helping physicians to do healthcare and manage patients. We're kind of at a transition point, I think, in healthcare, but I'm not against it at all. I want to use it. I just want it to be a little more seamless I want it to be something that's easy to use. I don't want it to interrupt my time looking into the patient and examining the patient. I want it to be seamless. I want to use it. And so, yeah, like I said earlier, I think that you have to take into consideration healthcare or electronic health record companies out there, what we as physicians do in order to make that happen. Because I think we all want the same thing. And so I think you have to consider recommendations and advice and insight and wisdom from physicians across this country.
Yesterday, we talked some about specialty-specific templates.
Yes.
And I think that's a great idea. I'd like to plug my national society, and that's the American Society of Breast Surgeons. What has been provided to us at this point, and if there is a specific EHR program, at this point I'm not aware, but there's a program called Mastery of Surgery where we enter data on our patients. It goes into an electronic program. It meets PQRS criteria, so you can get your PQRS bonus. It meets meaningful use. It meets MOC requirements. So just by participating in that one program that's provided by my national organization, I meet many of the criteria that are necessary to achieve the things that are expected of us right now. Now, they may have created a specialty-specific EHR program that I don't know of and can't comment on right now, but frankly, I am looking to them for helping us design that and then incorporate it into something that's bigger. And I would encourage other specialty organizations to do that for their members.
I agree.
Great. How's the microphone now? Okay. Well, I'd like to step in then for a moment.
Sure.
If that's all right.
Sure.
As Judy brought up, the AMA, American Medical Association, had their own town hall on EHR yesterday, a webcast, which coincided with ours. And we watched it. We were glad to see the AMA asking doctors across the country for their EHR experiences, and they were very interesting stories. One of the things I found really interesting was when Steve Stack, the president of the AMA, asked how many of the live attendees found EHR to inhibit or be detracting from their patient care. Every doctor there except for one raised his or her hand. Yeah. The other thing that's noteworthy there, and I don't know exactly how many attended, you know, there were occasional pans of part of the audience, but compared to the number of doctors that we all hear day in and day out in recent years complaining about these systems and the problems they're having, only a tiny minority are standing up, attending meetings like this, speaking out, and calling for change. And I know one reason is that doctors are so busy trying to comply with all these things, they don't have time to look up, and they are taking care of their patients, and they want to take care of their patients. But I want to say to you, physicians, if you think the current system is impeding your ability to properly care for your patients, then don't you think you owe it to them to look up from that grindstone for a minute, even if it means taking your attention away from them for a short time, and say that something's wrong here, something needs to be fixed. So if wanting to care for and take care of your patients is the issue keeping you from this, I say do it for them. I want to say that I want to tell you just a little bit about my politics so you'll understand that I'm not I'm not an anti-Obama person by nature. I've never really been a partisan. I've been an independent voter all my life. I supported President Clinton because I thought the country did well, especially economically. The thing that really turned me away from the Republican Party for a while was the invasion of Iraq in 2003, which I thought was unjustified. And I did vote pretty much Democratic for a while after that. I voted for President Obama, donated some money, and I supported his health care reform because I thought that the system we had at the time was harming many of my patients. But I never dreamed in my wildest dreams that healthcare reform would be put in place without consulting with practicing physicians. There was very little asking of us to participate, and there was very little interest in our feedback on how it was working. Two prominent physicians in this movement have told me that Senator Clinton, when she was trying to achieve healthcare reform in the 1990s, said, "We don't want physicians to participate. They'll just screw it up." Now, I haven't been able to find that quote, and I hope that's not her opinion. But in any case, we did invite President Obama, as well as Senator and former Secretary Clinton, to either speak at this conference or to send a delegated representative, and we have not heard back. All I got was a form letter saying the ACA is here to stay, even though I made it a point to say that we are not here to oppose the ACA. That's not what this conference is about. But I just want to ask the President, are you aware that 84% of American physicians 2 years ago said the profession was in decline, that 82% said there was little or nothing we could do about it, that last year 40% said they were going to accelerate their retirement plans, including the youngest physicians, because of these healthcare changes? So my question to you is, are you aware of that crushing morale in our profession or not? So if you're not aware of it, we ask you and your administration to contact us, and let's start working to change that. If you are aware of it, do you care? Tim? I call on my colleagues to take my own version of the ice bucket challenge. This morning I burned my draft card. And I invite you to do the same, or if you don't want to do that, I understand, although these things get damaged and lost all the time. I'm sure they'll send you another one. But if you have some other way to show your support that we need change, we need some relief now. We've been crushed for the past 5 years or more, and we've got to have some relief and some breathing space to focus on taking care of our patients. Let's focus on doing that first, until polls show that physicians and patients believe that that piece of the puzzle, that central piece, has been put back in its rightful place at the center of our profession. After that, we'll be glad to work with you to try to achieve data collection, increase and improved interoperability of EHR systems, whatever it may be. We'll be glad to try to work those in. But give us some breathing space to get that central piece back where it belongs, at the center of our attention. The Association of American Medical Colleges predicts in 5 years there will be a physician shortage of 100,000 or more. If you don't do something different, that's going to continue to grow.